us what the neglected proximal femur fractures, its
Proximal
guideline and
humerus.
manage.
Humerus.
Sorry, humerus. Yeah.
Non-unions, basically non-unions mostly.
Thank you very
Uh,
much, sir. Over to you, sir.
okay, thank you everybody and good evening. Today we are going to talk mainly about proximal humerus non-unions. This is a problem which unfortunately we do see from time to time. Although when you look overall at proximal humerus fractures, non-unions are relatively uncommon, but when they do occur, they can cause significant disability. This could be due to pain, the presence of a flail limb, and the surgical treatment can be challenging. Now, this paper by Coate Brown in 2008 analyzed the prevalence of proximal humerus non-unions and the assessment of their functional outcomes. And in a study of 11 proximal humeral non-unions taken from a prospective study of 1,027 consecutive proximal humerus fractures, which were analyzed for their prevalence, etc. And they found that the prevalence of non-union was as low as 1.1%, but it increased to 8% if there was metaphyseal comminution and 10% if there was between 33 to 100% translation of the surgical neck. So the more displaced the fracture was and the more comminution was there, the risk of non-union increased. And there was a deterioration of the overall glenohumeral function when you compare them with patients whose fracture had united. Now, what are the various factors which increase the incidence of non-unions? One is the initial displacement. It could be as a result of over-aggressive rehab. So if you're treating it conservatively, but you start movement and especially aggressive movement a bit early, then it may lead to non-unions. Poor patient compliance, that means if you have kept it in a particular position and the patient keeps moving it out of it, then you will get a chance of a non-union. Of course, comorbidities add to the chances with problems such as osteoporosis, alcoholism, and tobacco use playing their part. And in some of these non-unions, you can have interposition of soft tissues, which do not allow the fracture ends to unite. Now, what are the problems when you deal with these non-unions? One is the non-union itself. There is often stiffness of the glenohumeral joint. There could be fibrosis of the soft tissues. There could be gross instability at the fracture site. There could be malposition of the fragments, especially of the tuberosities. There could be loss of bone stock. And as I mentioned, the loss of bone stock could be also related to localized or generalized osteoporosis. Now, Chechia et al. Actually gave a classification of these non-unions, and they grouped them into 4 groups. One was when there was a high non-union in 2-part fractures. The second was when there was a low non-union in 2-part fractures. Obviously, the higher non-unions being more difficult to treat. You have complex non-unions where you could have multiple, so 4-part fractures where the tuberosities have also not united. And then you have lost fragment non-unions. And this is basically more in open fractures. And in the proximal humerus, basically, if it's 3 months down the road, or there is a situation where you know that the fragments are way out of position and there's no evidence of any healing, you can call it a non-union. Okay, now, is there a conservative treatment? Yes, you can try it if the symptoms are not significant and the patient develops some kind of fibrous union with which they can function reasonably well, then you can consider conservative treatment. Otherwise, it would usually mean surgery, and surgery usually would mean open reduction and internal fixation with bone grafts. Early on, we used to use the T plates, and then it came on to the angle plate plates. And finally, today, I feel that the lock plates have really contributed in helping us treat these difficult non-unions, especially because by then the bone stock is pretty compromised. And of course, you have arthroplasty, and especially today with the reverse shoulder arthroplasty, it could be a salvage for some of these patients with sort of very resistant non-unions or non-unions where you know that the chances of getting the fracture to heal are not very good. However, we are going to basically stick in this talk, in this lecture, about fixation and grafting to try and get the healing of these non-unions rather than consider arthroplasty. So starting with this elderly lady, 60 years old, but fairly osteoporotic, as you can see. This was an 8-month-old non-union, and you can see that there is no evidence of healing. There's a gap, there's displacement, and she had almost like a flail arm. Again, the CT shows you the gross osteoporosis and a clearly defined non-union, which is fairly high. So here we have to look at the condition. We need to bone graft. We know we have to bone graft. We need to freshen the bone ends and then get a good stable fixation. And in this case, we used a lock plate. You can see there's a lock plate put in a little higher than maybe ideally in a sort of early fracture, but you want to get as much hold as possible into this proximal fragment. There's a strut bone graft from the iliac crest, a corticocancellous strut graft, placed in the calcar region so that you have a good hold and good support, medial support. And then you can see how this, over a period of time, goes on to heal. And this is at about a 9-month follow-up, showing a reasonable function. It's not a normal function, but at least this arm, which had been lying flail for many months, is now functional to a great extent. So here are the various papers, starting with the papers in the 90s, which looked at a number of non-unions. And if you saw the early papers, the general results were not that great. And in this series, they were able to only achieve about 48% good results. Again, here another paper from 1996, where they had excellent results only in 5 patients, that is 25% in a group of 20 patients, and they had satisfactory results with 6, which is 30%, and unsatisfactory results in 9, which is 45% overall of the papers, of all the cases. So this was just showed that these fractures were quite difficult when they went into non-unions to treat. So Ring and McKee then started using a blade plate with autogenous cancellous bone graft in these non-unions and found much better results with good to excellent results in 20 to 25% of the patients. And then gradually we came on to the lock plates, which then gradually gave us better results. This is an interesting paper by Maheshwari et al., where they used a lock plate, but they used just a medial strut corticocancellous graft, which was used as a buttress. So in a fracture like this, they would not freshen up the non-union so much as to just put a strut on the medial side and put it on a lock plate. And they were able to show fairly good results using this method. Subsequently, there have been a number of papers using the lock plates with additional bone graft and sometimes fibular strut grafts going on to showing fairly good results. So we'll start with some cases where the non-unions are in untreated fractures. This was really 2.5 months, so just something going on to a non-union rather than an established non-union. But you can see that this fracture, the fragments where they are never going to unite. So there's no point waiting any longer with the hope that this will unite. You go in, you have to get the fracture ends freshened. You have to get them together in position and use a long plate, locking plate with bone graft. And then this fracture, you can see in the subsequent months, is going on to heal with a reasonable functional result. This is at 7 months post-op, and you can see the results tend to improve over the first year with these non-unions. They gradually get better and better movement. Usually The movements at 2 or 3 months may not be that good, but over a period of time, the movements and the function tend to improve. Here's another interesting case. This was a 3-month-old injury where you can see now the tuberosity is out of place as well. But here we were a bit worried at that stage to do anything to the tuberosities. And once we had got it kind of into a reasonably valgusized position, this was the CT scans showing the non-union. We sort of reduced it, got it valgusized, and fixed it with a plate, at a lock plate. And here we did not do anything to the tuberosity because at surgery, she was able to abduct her arm, or we were able to abduct the arm reasonably, leaving the tuberosity there. And we left it like that, and you can see how this has gone on to heal with a reasonably good function in spite of the fact that the tuberosity is higher up. As we've progressed with dealing with more of these non-unions, we've actually tried to bring down the tuberosity in some of these cases. And here you can see how with the use of a fibular strut graft, and where there is allografts available, you could probably do it with some of your osteoporotic fractures, even for fresh fractures. But this is a good way to treat many of these osteoporotic non-unions, where you can add a fibular strut graft, intramedullary strut fibular graft, to get you to heal these fractures. So here's a classical example where you can see this lady who had a 5-year-old ununited fracture. She had no surgery, but she was having a gross disability because of the flail limb. And she came to us for treatment. She had been to various centers around the country, but was not happy with the advice she was given. And here we decided to use a intramedullary fibular strut graft. We actually, if you can see that extra screw there, was because the shaft of the humerus was tending to kind of split if it as we put in the thick fibular graft in further. But we put a screw to hold that together, and we were able to get that reasonably well stabilized. We used corticocancelous strut grafts, corticocancelous strut, as well as chips to enhance both the biology and the stability. And that was the final post-op picture. And you can see with time how this has gone on to heal well. So this was the follow-up at about 4 months. You can see that even though this lady had not used this arm at all for about 5 years, we were now able to restore a reasonably good function for her. Next, we come to the group of patients who've had fixation of their fractures. And this is becoming more and more common because many of these fractures today get fixed, especially with the advent of the lock plates. But it has actually, in some ways, increased the incidence of non-unions rather than reduce it. And therefore, it's important that you do your fixations properly, because an inadequately fixed fracture is more likely to go on to a non-union than a fracture which has been treated conservatively. So here's an example of a patient and because of this, you see multiple problems that we have to face and deal with, and dealing with these non-unions which have been operated on before becomes more difficult than the non-operated non-unions. So here's an example. This was a young 45-year-old gentleman who had both a proximal tibial fracture and a proximal humerus fracture, which was fixed elsewhere. And he developed infection in the proximal tibial fracture, but that was the fixation of the proximal humerus fracture. So he came to us with these two problems. One was he was being unable to lift his arm, which was causing pain, but more than that, he came for the infected proximal tibial fractures. So we assessed this fracture carefully. These are the x-rays when we took, and you can see the head. There are hardly any screws which have actually entered the head proximal fragment. And this is one of the issues with the lock plates, because when you put on the screws, you do not get the biological, the haptic feedback that you get with conventional screws as you tighten them. So because the screws get tightened onto the plate. Okay, they lock onto the plate, so it will feel like they are holding very well when they may not be in bone at all. But on the other side, it was a boon for us because it made the fixation a lot easier. Of course, we had to get all the implants out. We had to freshen the bone ends. We had to get the fracture provisionally reduced. We had to get the tuberosity back in place, and then we could fix it adequately with this locking plate. This was one of the earlier locking plates, the Pneumalock plate, which we fixed with bone graft, and then it went on to heal. And we had to convert the proximal tibial fracture to a Ilizarov fixator, and you can see how he's doing quite well with this. Here's a patient with a fracture of the proximal humerus along with the tuberosity fracture, and this has been fixed with the tuberosity not adequately reduced, or the proximal fragment going into varus. And here we had to again take out the implants. Here, this was the position he came to us in, or almost 7 months after the fracture. We had to go in, we had to freshen the bone ends, we had to get everything reduced. We used these threaded wires to fix on the tuberosity fragment and the lock plate and strut graft to get the position back. And this is how he had gone on to heal with a fairly good function at the end of it. Now, the real challenges come in patients like this. This was a lady who had a fracture almost 6 years ago, 6 years before she presented to us. She had a non-union, which was treated at about close to 1 year after the original fracture. And this plate fell apart in very little time. Okay, and the interesting thing is after that, the proximal fragment got abducted and the distal fragment was adducted. And this was the position she was stuck in. And there were multiple issues to look at before we could deal with this fracture. There was the non-union itself, the fact that the bone stock was poor, the previous implant, which had multiple screws, which had, again, some of them had broken, so we had to remove all these implants. The plate had broken. There was severe, a lot of fibrous tissue at the fracture site. But the biggest problem was the position of the proximal fragment. So we went in through the deltopectoral approach. We removed all the implants. We freshened the bone ends, and then we had to really mobilize the proximal fragment that is between in the coraco, in the acromial, subacromial space. We had to release all the fibrous tissue there so that the proximal humerus fragment could be mobilized. And because there was so much stress at that level, we decided here to use an intramedullary strut fibula. We used a locking plate and additional cancellous bone grafting. So that was the post-operative X-ray. We kept this lady in an abduction splint for 4 weeks before starting mobilization. This was the X-ray. This is 6 weeks follow-up. Again, you can see the strut graft there, the lock screws again in various directions. And this was her at 8 months. You can see how now this fracture has healed up nicely. The sort of fibula is incorporating. It's serving both as a biological structure as well as a mechanical strut for the fixation. You can see there's some of the screws from the plate go through the fibula onto the head. And this was her at 8 months with fairly good function. And you can see how she's able to move her arm and get back a reasonable function, even in such an old non-union. The next problem, which I talked about earlier briefly, is when maybe the fracture heals, but the tuberosities are way out of place. So this was a 50-year-old gentleman who was treated like this with a lock plate. And you can see now how the tuberosity fragment is still lying on the top here. So you can see that the tuberosity fragment is still lying here, and this has not been reduced adequately. This is what he presented to us at 2 months, being unable to lift his right arm. Again, you can see the tuberosity fragment here. These are the other X-rays we got done. The CT scans, again, we can see again on the CT scans, the tuberosity fragment lying here. So here, even though this fracture may have healed otherwise or may have gone on to heal, we really needed to get this tuberosity back to get function in terms of the shoulder. So those were all the CT scans. Again, you can see how the tuberosity fragment is lying separate. And here we had to go down, remove the implants, get the tuberosity fragment mobilized. Okay, so we had to actually mobilize that tuberosity fragment, bring it down. And here we used stainless steel wires rather than sutures to get the tuberosity nicely fixed against the uh, tied onto the plates and also reduced adequately onto the correct position so that the tuberosity was at the right level. And you can see how at the 10-month follow-up, he's got back quite a reasonable function. You can see how the tuberosity has now gone on to heal in the correct position, and he's doing quite well. Here's another case where this was treated conservatively. Again, you can see how the tuberosity fragment is lying up there. These are the X-rays subsequently at 2, 3, 4, and almost 5 months before she presented to us. She could lift her arm to some extent. If you can compare it to the left side, it's much less. And of course, the internal rotation is also grossly reduced. So this was another situation where we thought we'll osteotomize this, we'll get this down, we'll get this reduced adequately. And it's not easy. Getting this whole fragment down to the correct place with its attachment is not easy. So anyway, so those are the CT scans to give us more information. You can see how the fragments are out of place, the tuberosity is out of place, and we kind of osteotomized the tuberosity and the neck. We got it reduced adequately. We got it fixed in a reasonable position and then started. This is an abduction splint. She was kept in for 3 to 4 weeks and then started with mobilization. And you can see over a period of time, she got back quite a good range of motion. You can see the post-op X-ray, not the best X-ray, unfortunately. She managed to spoil these X-rays by the time we got the X-rays, by the time we got photographs of them. But she regained quite a good function at the end of it and was quite happy. Of course, she did have some pain, and eventually we removed the implants. And the last group are infections, and this can be a real problem. Here, you can see that the infection was obvious. There was a discharging sinus, and there was stiffness in the joint and obvious instability at the joint. So here, we went in, we debrided it thoroughly, we got rid of all the necrotic bone, and then we had to work out how to stabilize it. And in this case, we felt because the infection was so bad, probably an external fixator would be the best option. And here we used hydroxyapatite coated pins for the proximal fragment so that you would get a good hold in the humeral head, even though it was an elderly gentleman. So you can see the clamp compressing the two ends of the fracture, and then the shank screws being put in, and also antibiotic beads to combat the infection. And luckily, things went on to heal. He didn't come back till about almost 6 months down the road. Okay, that is 6 months. And you can see by now the fracture had healed. So although the original plan was to convert it to an internal fixation once the infection was controlled, he came to us when the fracture had healed, although in slight varus, but we decided to accept this, remove the fixator, and he went on to do reasonably well. One last case, which is what we will do with infections today. This is one paper by Wallow himself about doing a new classification for some of these proximal humeral fracture sequelae, where he's divided them into 4 groups, where there could be non-unions of the neck or the tuberosity malunions or dislocations, etc. So these are a complex group of fractures which can be difficult to treat, and he treated them with mostly with a prosthesis, and subsequently was using reverse shoulder prosthesis for this. So in conclusion, neglected fractures of the proximal humerus can be a challenging problem. Non-unions usually cause significant disability. Successful treatment of these non-unions are possible with proper techniques, and reserve arthroplasty, and especially reverse shoulder arthroplasties for the elderly with very high non-unions where reconstructions may not be possible. So you have to make a judgment call on that. And wherever you think it's possible, we have techniques and methods to fix these fractures adequately, give enough biology for these fractures to heal, and get back a reasonable function. Thank you very much for a patient hearing.
Thank you very much, sir. While we are waiting for questions, sir, one thing which we have explained what is strut graft, sir. So how to put the strut graft in case of this type of non-union with poor bone struck?
So the way we do it, I mean, there are some people may use different methods, but what you need to do is to first take the fibula graft the usual way. If we don't have access to allograft, so we have to use autograft that is from the patient. So we have to consent them for that before we do the surgery. You have to be careful not to cause any complications at the donor site. And the most common complication is a toe drop, which in our experience has usually recovered, but probably 1 in 10 of our cases of fibula grafting, we have had a toe drop postoperatively. Then you need to measure the medullary canal diameter of the proximal humerus, okay? Because sometimes the fibula can be too thick for it. If it is fitting nicely, then you can put the whole fibula graft. Otherwise, you have to make the graft a little thinner so that it can go in without too much difficulty. You also need to freshen the proximal humerus and create a slot on it for this humeral shaft for the fibula graft to go into. Okay, and usually we try to keep it a little medial. Okay, then when we are fixed, so you have to reduce the fracture, do all this, and then when we are putting on the plate, we try to put some of our screws which go into the head through the fibula graft. So because the head will be very often very osteoporotic, so you want to get increased hold in that by using this strut screws, which actually lock screws, which actually go in through the graft, or even some conventional screws which may go in through the graft into the proximal fragment. So that is how we do it. I think there are some people with slightly different techniques. Sorry, the lights have gone off. It'll come back in a minute, but you won't be able to see me. You can probably hear me, but not see me till the lights come on. Okay.
Okay. So we have few questions in the chat box, sir. May I ask right now, sir?
Yeah, sure. Because
Rajan has asked about how to manage stiffness or frozen shoulder in proximal humerus fracture, both operative and non-operative management.
So there are 2 or 3 things. You're talking about a fracture which has been fixed and the patient is not getting back mobility. So I think in the early stages, you can do a gentle manipulation. And if you're sure about your fixation, and that is good, sometimes, so you need to start early mobilization. That's the first thing. Because if you don't start reasonably early mobilization, then the chances of stiffness increase. If you catch it at about 6 weeks or 8 weeks, then you can try a gentle manipulation under anesthesia to get back movement. But if it goes longer than that and you cannot get movement with physiotherapy, then you may have to think of something like a arthroscopic arthrolysis. So when I say you do a manipulation, it'll be if there's gross stiffness, okay? A lot of them are reasonably mobile, but not fully mobile, and that mobility improves over time, okay? So over 3 months, maybe they're moving only about that much, but by 6 months, 9 months, they'd have got much better mobility. So if it is grossly stiff at 2 months, then think of manipulation. Otherwise, it will be just physiotherapy exercises, active and active assisted mobilization exercises. There could be osteoporotic bone. So if you use too vigorous physiotherapy, you can fracture elsewhere. Okay, so these are the precautions that you need to take. And last you have the option of arthroscopic, and finally you have the option of open arthrolysis, which you can do when if the fracture is healed and you are thinking of taking out the implants. Okay, sometimes it could be impingement of the implants, so that you have to need to deal with at the time of implant removal. But
Another question.
first and most important is to find the cause of the stiffness. Okay, now sometimes it could be a result of chronic regional pain syndrome, okay, or what we used to call um,
Shoulder
RSD
tension.
or whatever. So if that needs a different sort of treatment altogether.
So another question asked by Dr. Subhanshu is what to do when patient treated by fixation or fracture dislocation came with non-union and chronic posterior dislocation of shoulder. That it happens that with some patient presented quite late in fracture
Yeah.
dislocation cases.
So actually, we with the posterior dislocations do reasonably well even when treated quite late. Okay. So we've done them as late as 8 months or 9 months. I think generally after 3 months, they become more and more difficult. So if you're trying to do that after 3 months, you should have enough experience with doing this kind of surgery. I think up to 6 months, many people have shown reasonably good results. You would usually need to combine it with a modified McLaughlin procedure, which would be a osteotomy of the lesser tuberosity, which you fill into the defect which is caused by the posterior dislocation. Okay, so this would be in fracture or in a pure dislocation. You will end up with a large defect in the head. So that needs to be, when you do, you put, so because your limb is internally rotated, when you externally rotate, the defect will be just anterior to the joint. So I mean into to the anterior part of the head, just anterior to the glenohumeral joint. So it will tend to slip back in if you don't fill that defect. Okay.
So that how to reduce that one, sir? That is quite difficult.
So reducing it is something that you have to go very carefully. So what we do is you need to find the rotator interval. Okay. So that rotator interval is the space between the lesser tuberosity and the greater tuberosity. You follow the long head of the biceps all the way up to the glenoid. And once you do that, you are into the glenoid. You need to release the fibrous tissue, get to the back of the glenoid, and then release all the fibrous tissue, and then gradually try to gently get the head out. You can use something like a Murphy's, especially slightly, not the metal, but a rough, sort of stiff rubber Murphy's, if you have that. You use various instruments to try and release the fibrous tissue between the uh, glenoid and the head. Okay, and then you have to gently lever the head back into position. Okay, so that is very important. You have to do that carefully, slowly, and with care, because you can end up with bleeding as well as damaging the head in that process. If it's very late, then you have to think of things like an arthroplasty. And here again, if you have to think of an arthroplasty in the elderly, probably a reverse shoulder arthroplasty will be a better option. But in the young, you cannot do that. Okay. And finally, you also have the option of an arthrodesis. Okay, so if the joint is so damaged that it's not worth reconstructing, then in the young patient, you can think of an arthrodesis.
So
Because you
during
have
reduction,
a reasonable amount of gleno movement between the scapula and the shoulder and the chest. So the scapular movements can to some extent help you with your shoulder movements.
so one more thing, sir. While as you told that after excision of the fibrous tissue in between, so sometimes the upper fragment is quite small, the head part, sir. So how to judge how much to debride or the
So you don't debride the head, you debride the fibrous tissue. Huh? So you need to try and retain the head completely, because otherwise you are going to have nothing to fix onto. Okay. As many of these posterior dislocations are actually posterior dislocations which have been missed, or they could be fracture dislocations. So both things, but relative to anterior dislocations, the old ones, especially after 3 months, uh, the posterior dislocation tend to be more disabling. Some of the anterior dislocations get back a reasonable function. Also, doing the anterior dislocation late, the results are not as good. So, and you have the vessels, the main vessels right there in front of you. So you have to think very carefully about doing something in those situations.
I think uh,
Okay.
the last case you have shown about the infected ones.
Hmm.
So, what is the management different other than debridement? Is there anything?
Yeah, so I had one more case, somehow it's not there, where we do primary fixation with lock plates. Okay, so because it's shoulder, especially if it's osteoporotic bone, putting on a fixator is not easy. Okay, and you're likely to lose your. So we tend to do a thorough debridement, get rid of all the necrotic tissue, and then fix these primarily with a lock plate. Okay, using only lock screws. So it works almost like an internal fixator. Here we would add antibiotic, cement, either a block or beads, depending on whether there's a defect which we have to cover. Defect in the bone that we need to fill. Okay, and then in that case, we would go on to a mascale later, or we would bone graft it later if we have used beads. Okay, so uh, very often when we go to bone graft it, we add an additional plate, an orthogonal plate, to increase the stability, and they do quite well. So our results have been fairly good, because using an external fixator, although I showed a case with the external fixator, the case with the lock plate seems to have got misplaced in the final arrangement. But we nowadays, our primary method of treating these would be to fix it with a lock plate where it is salvageable. Okay, where the shoulder is gone, then it's a totally different situation. Then you have to think of either an arthrodesis or an arthroplasty.
So before planning, is it always necessary to take a CT or
PT meaning?
CT
CT.
scan, sir? Yes.
Yeah, I think nowadays for most of these, we would do a CT before surgery.
So,
So most of these cases, I mean, if it is, especially if it's involving the tuberosities, we would definitely get a CT. If there's any doubt about any subluxation or dislocation of the joint, we definitely get a CT. And so unless it's a sort of surgical neck or more distal fracture, I think a CT is important in this.
and in any case, sir, MRI is also required or just CT?
MRI, so if they have previous implants, then MRIs become more difficult. Uh, if they've not had surgery, then usually we are not worried about AVN so much, because AVN here, even if you do get AVN, it's not necessarily a very big functional problem, not always. Okay, so as long as your head size is reasonable, you would try to go and fix it, you, whether you exclude AVN or not. Okay.
So, as you told, sir, plasty is always another option in cases. So, what is your consideration for
So
arthroplasty?
our consideration for arthroplasty is where we do not think you can fix it adequately. That's the only one we'll consider for arthroplasty. And in the older patient with osteoporotic bone, that may be a no.
So, in
Younger
your
patients, if we think that the joint is gone, we might go for an arthrodesis rather than an arthroplasty. When you're saying young, I'm talking about below 45, 50. Huh?
So in one study, you have shown that even with 100% translation, there is chance of 33% of non-union.
No,
So
no, no.
even the
So, no, no. If there is 33% 200%. So if the translation is more than 33%, the risk of non-unions goes to 10%. Okay, in that study. Okay, it's not 100% non-unions. Okay.
Yes. I think, sir, most of the things we have covered, sir.
Sure.
So it was great, sir. Great
Okay.
learning.
Thank you very much.
And for this one, sir, your publication, what was submitted was accepted for February 2024. So it will be
Sure.
available.
So that
Sir.
is only for the very
Maybe
old non-unions where we've used a fibula
yes, sir,
or
more than
strut
5 years
graft. So
of
that,
non-union.
sure. Somehow we have a group of patients with presenting that late, so that's unusual. Okay, thank you very much, everybody, and
Yeah.
till next week.
Thank you
Bye.
very much, sir. It was great.
Sure.